Hey guys, welcome to the third and final part of this lecture on expansion disorders. Once again, if you click on the notes for this title slide, you can see the outline of the lecture and kind of see what we're going to cover and where it's at. If you guys remember, we ended part 2 talking about the neurological subset of extrinsic disorders, specifically pathologies that involve damage to the nerves themselves. So now we're going to pick up with disruptions at the neuromuscular junction. So we talked about disorders that can damage the nerves or parts of the nerves which control your respiratory function. Now we're going to look at disruptions at your neuromuscular junction, so it's a good time to review what exactly needs to happen at that junction. So for your nerves to be able to control the muscles of your thoracic bellows, they need to be able to release the appropriate neurotransmitter. That neurotransmitter needs to be able to travel from the nerves to the muscles and needs to be received. That's how the communication happens. So given that, the two examples we're going to look at that disrupt that process are botulism and myasthenia gravis. So botulism is a bacterial infection, and apparently this bacteria releases a really powerful toxin that is lethal to humans when inhaled, even in small amounts. Apparently 1 microgram is lethal. The way it works is that it inhibits the release of that neurotransmitter we were talking about, acetylcholine, from the presynaptic membrane. So you can't get your messenger out, which means you're blocking that communication, so the muscles responsible for respiration don't know to do their job. I didn't realize that the botulism toxin was so powerful or so dangerous. My familiarity with that toxin prior to getting into EMS was just, Botox injections, whatever. But clearly, what they use for cosmetic purposes is a lot less than what we're talking about here. So the paralysis associated with botulism moves in the opposite direction from what we learned with Guillain-Barré. So it starts with your face and then moves down. So it doesn't take too long before it gets to the muscles of respiration, which is why I think, in part, is why it can be so lethal, right? Because it gets to your more vital musculature sooner. So, because botulism can progress to respiratory paralysis, it is considered a medical emergency. It's also a public health issue. It's not that botulism is contagious from person to person. You can't catch botulism from somebody you're in contact with if they have it. But what it is however they caught it, if it's foodborne, then everybody who ate that same food could get it. So that's kind of where the public health aspect comes in. They want to track everybody who, maybe is eating the same food. It's common in infants. They're not exactly sure why. They think it's something about the gut flora in, infants, right? So when you're younger, something about the gut flora in infants makes it a really hospitable environment for this bacteria. So it flourishes if it gets in. And infants, I guess, they get introduced to it when they're fed honey, because apparently honey is a really good vector for this bacteria. So you've got a good vector and you're feeding it to somebody whose gut flora, by virtue of their age, just happens to be a really hospitable environment. You put those two together and you've got bad news. So what could botulism feel like to someone who has it? If it's foodborne, they could have abdominal cramping, they could have nausea, vomiting. It could progress to bilateral weakness as opposed to a unilateral weakness, which you might associate more with a neurological event like stroke. We talked about how it starts with the face and moves down. So now, as it progresses into the throat, you might have dysphagia, trouble swallowing. So when you think about it, this could start to be respiratory compromise before you even get to the thoracic bellows, because if you have trouble swallowing, you're having trouble protecting your own airway, right? And then obviously it can progress all the way to respiratory depression and distress. So here's a picture, 14-year-old male who eventually was diagnosed with botulism. Uh, when you look at the picture on the left, he looks like he's just gorked out, which is not the technical term, but um, looks like he's half asleep, having trouble staying awake. His face is very flaccid. On the right, someone there is opening, is holding his eyes open because he can't even do that on his own. You can see, even under this bright light, that his pupils are not really reactive. They're still really dilated. The interesting thing about this is, the caption to this picture at the original source came from Wikipedia. This kid was, conscious, fully awake, oriented, knew what was going on, but, this was what he could do with his face. All right, so now we're going to move to our second example. It's myasthenia gravis. Like Guillain-Barré, it's an autoimmune disease. And like botulism, the pathophysiology occurs at the neuromuscular junctions. But unlike botulism, whereas botulism inhibits the release of acetylcholine, myasthenia gravis attacks the acetylcholine receptors on the muscle cells. So now you can release as much acetylcholine as you want, but the muscles just don't have the receptors to read that message. So with this disease process, over time, your muscles are less and less able to receive the message to work because they just can't read that acetylcholine. You can get extreme weakness. It's interesting that, like botulism, it apparently starts in the face and throat. You can get double vision from the eye muscle weakness. You can get the drooping of the eyelids, which we just saw you could see in botulism. So for us, pre-hospital in the field, we're not necessarily gonna know, you know, if we're dealing with one or the other per se, but just kind of things to keep in mind. A couple of things you could be dealing with if you see some of these signs and symptoms. So this process can occur at any neuromuscular junction. Its relevance here is when those neuromuscular junctions are between nerves and muscles of the respiratory system. Um, there's a bunch of different treatments, drugs, you know, removing antibodies from the blood. Also, removing the thymus gland. If you guys remember, the thymus is supposed to be larger and more active in childhood. It helps produce cells which eventually become cells of the immune system, the T cells. But by the time you reach puberty, it's supposed to have physically shrunken down and its function is supposed to have diminished. What they're finding in some adults who eventually get diagnosed with myasthenia gravis is that their thymus never shrank. So it's still big and it's still kicking out all these immune cells, um, which is basically, the system gone haywire. And so there's too many of them, they're overactive, and they're attacking healthy muscle cells, the receptors on those muscle cells. So, whether these neurological respiratory disorders are due to damage to the nerves themselves or disruptions at the neuromuscular junctions, what are some of the symptoms? Honestly, the same kinds of symptoms you'd find due to any inadequate ventilation. I mean, it's that general, right? So you're going to have fatigue because you're not getting enough air, you're not moving enough air. Impaired control of secretions is basically the secretions you have trouble, keeping them where they're supposed to be, right? You can't protect your own airway if you're having swallowing problems, stuff like that. Um, Same thing with this lower respiratory tract infections. If you can't expand and contract as well, you're not moving as much air, so you're not helping clear things out in there. And it can progress, right? First, it's dyspnea upon exertion, then it's even at rest, and if it progresses far enough, respiratory failure. So one of the things your patients might tell you is that they actually have a history of episodes of respiratory failure. With a disease like myasthenia gravis, over the course of the disease, even though it tends to be progressively worse, um, in that progression, you can have like an ebb and a flow. You can have periods where your muscles are more receptive to the acetylcholine and periods where they're less receptive. So you can actually have episodes of respiratory failure that you recover from. The pulmonary hypertension is a result of the fact that your body is actually pretty smart. And when it detects that there are areas of your lungs that aren't getting ventilated adequately, it'll actually tighten the vasculature in those areas so that it's not wasting, it's not sending blood where ventilation isn't happening. Um, so blood then goes to areas of your lungs that are getting ventilated more adequately. But the point is, in constricting those vessels where your lungs aren't getting ventilated adequately, you end up with this pulmonary hypertension, which can then lead to cor pulmonale, which is basically an enlargement of your right ventricle. Because if you guys remember the way your blood flows, it's your right ventricle that pumps blood to the lungs. Now, if you've got high pressures in your lungs, your right ventricle has to push against all of that pressure. You can have either right ventricular hypertrophy, which is the thickening of the muscle walls, or you can have dilatation, which is just an expanding of the chamber altogether. Neither one is good. You know, at first it might seem that a thickening of that muscle is good because we think about, muscle hypertrophy like if my bicep gets thicker, does that mean I can lift more with my arm? The heart is not the same, right? Like you get that thickening of that muscle, and what it actually does is decrease the available space inside that chamber. And then with the dilatation, if you guys remember um, your Frank Starling law, you know, the force of your ventricular contractions has a lot to do with how much that chamber is stretched. The more stretch you have, the stronger you come back and snap back like a rubber band. Well, if you're already dilated, as they say, you're already ballooned out, you're weaker. You're already pre-stretched, so to speak, so you can't really snap back as hard. Either one is basically right-sided heart failure. So, what might some of these neuromuscular respiratory disorders look like? Um, Basically, it'll look like someone who's trying to compensate for not being able to use their normal muscles properly, right? So, accessory muscle usage, increasing their rate to compensate for a decreased volume, and then also for those whose diaphragm is either partially or completely paralyzed, you might see some paradoxical breathing. So this is just a picture of the muscles of respiration so you can see what I mean when I say accessory muscle usage. But it's also just kind of a nice review of all the muscles of respiration. Inhalation is an active process, usually, right? So the dark blue box, shows which muscles are principally used for that. To the top right, the light pink box, you know, expiration under normal circumstances is passive. And then, the darker red lower right box is when you're forcefully pushing air out. You're basically using a lot of the same muscles you use when you breathe in, with a few additions. But anyhow, the upper left light blue box is your accessory muscles. So normally you just use those to help out when you're breathing in. But if you, for whatever reason, can't use your muscles normally, then your accessory muscles become kind of your prime movers. So, paint is just a mnemonic that's sometimes used to help remember the different causes of restrictive lung disease. The letters stand for pleural, alveolar, interstitial, neuromuscular, and thoracic cage abnormalities. So, here's how this categorization system breaks down. Um, Pleural diseases are going to be extrinsic problems, right? So we talked about scarring, we talked about effusions. Alveolar problems are going to be intrinsic because it's in the lung parenchyma. So you got your asbestosis, silicosis, black lung, farmer's lung. Any of those will cause inflammation and scarring intrinsically, which will result in trouble expanding, right? Because now your tissue is less pliable. Interstitial, also intrinsic, like sarcoidosis, which we talked about, with some pictures. Neuromuscular, we just covered. So polio, muscular dystrophy, Guillain-Barré, myasthenia gravis, ALS, botulism. And then last, the thoracic cage abnormalities, which are extrinsic. They're the thoracic bellows. So you've got the obesity hyperventilation syndrome, the kyphoscoliosis, and we also mentioned things like ascites. So, just a point of clarification because I don't want to oversimplify, you can have both obstructive and restrictive problems, right? Um, and it can go either way. You can start with an obstructive process, um, like COPD, which could then lead to pneumonia, which, if it becomes severe enough, can lead to restrictive problems, right? If you have enough consolidation, now you lose that pliability, now you can't expand your lungs as well as you normally would. We also talked about how it can go in reverse. You can start with a restrictive problem, like the example we visited was kyphoscoliosis, and if you chronically cannot expand your lungs enough, then you have trouble clearing out those smaller air passages, and you can develop um, infections which can be obstructive, right? So you can't have both, and you know either one can cause the other. So let's finally circle back now to our patient from our case study, trying to figure out what's going on. If you remember, our patient had fatigue, heaviness, weakness, kind of flaccid, symmetrical in all these ways, but did throw positive on the Cincinnati because of his slurred speech. So, stroke is definitely at the top of your um, index of suspicion. Also concerning is his low O2 sat and his high capnography. Obviously, he's hypoventilating in some kind of fashion. And you do remember that he mentioned he has a past medical history of asthma. The thing is, he specified it was childhood asthma. He says he only uses albuterol PRN, and kind of the big thing, his lung sounds are clear. They're diminished, but they're clear. And like we said when we first saw it, his waveform is square. It's not shark fin, so it doesn't imply an obstructive process. Like it's not showing um, that slant that would show that the CO2 is coming out gradually, because it's obstructed either by bronchospasm, bronchoconstriction, or any other kind of lower airways obstruction. It's square. So he doesn't have trouble getting his air out, but he's obviously hypoventilating in some fashion. So hopefully, with his fatigue, which it turns out you're starting to figure out is most likely due to his hypoventilation, Um, with that, with kind of his droopy affect, right? His heavy lidded look, his sluggish pupils, his kind of slurred speech, his kind of flaccid affect. Hopefully, you're thinking something neurological. And I mean, you are, right? Stroke was the first thing. But also now, hopefully you're considering could also be any one of these other things we talked about. This, uh, I can't say it, but Guillain-Barré, botulism, myasthenia gravis. Drilling down even a little bit more, taking into account not only all of these signs and symptoms, but specifically the GI disturbances, right? The nausea, the vomiting, the diarrhea, the abdominal cramps, the distension, the tenderness, and the story you were told that he and his wife 24 hours ago had canned food from sister-in-law who just recently got into canning. So, is it possible that being new at it, she mistakenly canned some foods improperly, and maybe we're thinking now foodborne botulism. So what do we do for our guy? Well, first and foremost, we recommend that he let us take him to the hospital because he might be suffering from a stroke. Um, Even if we're thinking it could be botulism, both of these, if you recall, are considered medical emergencies. Luckily, he agrees to go. So your treatment route is mainly going to be supportive. You're going to administer low flow supplemental oxygen, right? Because he was satting in the high 80s on room air. You're going to establish IV access. Try a 250 ml fluid challenge because he's a little dehydrated. Could also help with the nausea. And might as well keep him on the monitor. A lot of things could happen. Another thing you can consider for nausea is an antiemetic. When I suspect that someone is nauseous because of something that they've eaten, um, I sometimes steer clear of an antiemetic if I think that it would help them to actually throw up whatever, you know, poisonous thing that they ate. But this guy, I mean, unless I'm afraid that then they can't protect their own airway. If I think vomiting would be an aspiration issue, obviously that's different. Then they get an antiemetic. The thing about this guy is, he ate this food 24 hours ago. He's way beyond the possibility of throwing up anything that poisoned him. So, you could argue an antiemetic is also appropriate in this case. I apologize that I wasn't really explicit as far as when did these patients' symptoms ensue. I did say he was saying, we ate about 24 hours ago. It's the last 24 hours. I've been feeling this way, but I didn't really specify, well, exactly when did the weakness start? Exactly when did the slurred speech start? If you're suspecting stroke, it's really important you figure out when last known normal was. Um, that being said, regardless, if you are suspecting stroke, then early notification is appropriate. And again, try to get that good history. I'm sorry, again, I didn't necessarily provide it as far as that goes. You also explain CPAP to your patient. Just it's another tool you can use in case he actually does start to develop respiratory distress en route, because it's clear that he's having trouble ventilating, right? So this is relatively non-invasive. He agrees to try it. You just need to make sure that he stays within the parameters of eligibility, right? Like he has to stay as lucid, as oriented, as conscious, as able to protect his own airway as he currently seems to be. And his pressure is a little borderline, right? So, he's got about 10 more points on his systolic to go before you want to kind of not put him on continuous positive airway pressure. So, just another tool to keep in mind. Okay, so in summary, and it's good we're here now because we're just a little bit over 20 minutes, so sorry for that. We went over hypoventilation, which is basically due to an inadequate respiratory rate and or inadequate respiratory volume. So really what we talked mostly about was inadequate volume. Speaking of that, we talked about how you can have obstructive lung disease or restrictive lung disease. And again, obstructive interferes with your ability to get your air out. Restrictive interferes with your ability to get your air in. Got deeper into those restrictive disorders, talked about how they can be intrinsic or extrinsic in origin. We highlighted the neurological subset of extrinsic restrictive lung disease. We touched on the patent mnemonic as another way to categorize restrictive lung disease. And finally, throughout, we kind of kept in mind a case study, a theoretical patient with an expansion disorder, saw how that might present, what they might tell us, what they might look like, and how we might manage that patient, including what our differential diagnoses might be. So that's it, guys. Thanks for hanging in. If you have any questions, comments, or concerns, please contact me at ccruz32@cnm.edu.